This teleconference is being presented by the Harmarville Rehabilitation Center in Harmarville, Pennsylvania.
I would say probably the most positive aspect in my mind of what we have seen using the Bobath approach is that as professionals working with these patients, we realize how much potential the patients do have. We're not satisfied with the things that we were satisfied with before. We're not satisfied seeing the patient walk along with a brace and a quad cane and move very abnormally, but we realize that the patient has more potential than that.
Well, in all the years I've taken care of stroke patients, to me, the Bobath approach has probably brought about the most encouraging and optimistic opportunities for nurses to really integrate therapy and nursing care and to really become involved in the total programming. It really has given that opportunity for nursing to make a difference.
I think that it does make it a lot easier for the patient to integrate and to relearn, because that's essentially what they're doing, is relearning how to move themselves. They're relearning the basics, what they learned when they were a baby. And if we can all be very consistent about that and have them learn the same thing all day long, then hopefully they're going to integrate things faster, learn things faster, and hopefully be more functional.
Hello, I'm Susan Cosgrove. Welcome to Bobath Techniques for the Stroke Patient. Today's teleconference is being presented by the Educational Resources Division of the Harmarville Rehabilitation Center. We are particularly excited about this teleconference. It's the first attempt, to our knowledge, at presenting a clinical seminar to a mass audience. Through the convenience of teleconferencing, this program is being carried by satellite to about 4,000 people at nearly 100 viewing sites. To all of you at our receive sites and to everyone here in our studio audience in Pittsburgh, Pennsylvania, welcome. We are glad to have you with us for this unique event. Before we begin, I'd like to describe the format of today's teleconference. We've organized it as a comprehensive and, we believe, efficient introduction to Bobath treatment techniques. If you take a look at your teleconference information packet, on page 2, the table of contents, you'll see that there are 8 content sections. They include an introduction to the principles of Bobath, basic principles, problems in hemiplegia, 24-hour management of the hemiplegic, transfers, activities of daily living, the hemiplegic shoulder, and adaptive equipment. This information will be presented through lectures, demonstrations, and discussions, and supplemented with various graphics, displays, and pre-recorded video segments. We have also scheduled 3 question and answer sessions during the program. One of the advantages of a teleconference is that you can not only see and hear our instructors, but also talk with them directly, asking questions and making comments just as you would at any meeting you attend in person. Here's how the question and answer process will work. Over the next 4 hours, if you have any questions or concerns that you would like our presenters to address, jot them down on a piece of paper and forward them to your site coordinator. He or she will then call us, collect, at area code 412, number 621-7161. The teleconference staff will make note of your question, and when it's time for a telephone segment, they'll call you back and put you on the air. We'll take just as many calls as time permits. Also, there are 2 breaks scheduled within the teleconference. Each one lasts about 15 minutes. During them, feel free to stretch your legs and just relax a bit. One last note about your teleconference information packets. The information to be presented today is outlined in the packets in the exact order of presentation. The outline contains all the graphics, charts, displays, and definitions and descriptions that you'll be seeing and hearing. We've done that so that you can concentrate on the presentations and not have to worry too much about note-taking. Now, some people who've registered just within the last few days don't have the information packets. What we would like to ask you to do is share with each other for today, and then if you'd like a packet later, just write to the Harmarville Rehabilitation Center. Your site coordinator can give you that address. Now, I would like to introduce to you our instructors, Louise Lipitz and Jan Davis. Louise, a physical therapist, is a clinical instructor at the Clinic Valens in Switzerland. A certified Bobath instructor, Louise has worked extensively with Berta and Karl Bobath, the founders of the Bobath approach, and has taught Bobath courses both in Switzerland and in the United States. Louise, I understand that although you work in Switzerland, your home really is in Minneapolis.
Yes, that's exactly right. I was able to come home for Christmas this year, so I really enjoyed being with my family. Mm-hmm.
Now, you don't speak English in your work in Switzerland, right? You speak German, I assume?
Yes, that is exactly the problem. We speak German, and I've been over there almost 10 years now, and I'm having a little bit of trouble adjusting to the English language. At least I've been here 2 weeks, so I hope things go all right for us.
We'll forgive you if you lapse into German occasionally.
Thank you.
Our other instructor, Jan Davis, is an occupational therapist currently in private practice and consulting in San Jose, California. Jan, too, has worked with the Bobaths and, in fact, was the director of occupational therapy at the Clinic Valens. Jan, I understand that you just recently returned to work here in the United States.
We came back this summer. About 4.5 years ago, I moved over to Switzerland with my husband, and we thought we'd stay just 2 years. We ended up staying 3 years and then 4 years. And each year we were lucky enough, Louise and I, to come back and teach courses here in the United States together. Mm-hmm.
So you have taught Bobath courses together extensively, then?
Right,
Good.
right.
Okay. Well, welcome to both of you. We're glad you're here.
Thank you.
Without any further ado, as they say, let's get to the business at hand. Our first subject area for today is an introduction to the principles of Bobath. There are several theories or approaches in use today in the treatment of hemiplegia. The one we're discussing here, of course, the Bobath approach, was developed by Berta Bobath and her husband, Dr. Karl Bobath. Louise, will you tell us a little about how this whole Bobath approach began?
Oh, I'd really love to. I think it's always interesting to hear a little bit of the history, not the whole history. But Dr. and Mrs. Bobath, of course, are from Europe. Actually, she grew up in Germany, and he is Czechoslovakian. And the two of them went to England in about 1938. Mrs. Bobath, I think we have a picture of her, was actually the main developer of this technique. And she was working with an adult hemiplegic when she discovered her theory of inhibition of spasticity. It's interesting because most people think that probably she was working with cerebral palsy children when she developed this, but that was not the case. The first one was a portrait painter who had a spastic arm, and she was just handling this arm, and all of a sudden she says, "It's relaxing, my goodness," and told her husband, and he said, "No, that's not possible." And she said, "Oh, yes, it is." And from then on, they've been working as a team. He's been trying to explain why it works, and she has just been developing the manual part. Mm-hmm. Now, I met Dr. and Mrs. Bobath in 1975 when I took my first basic course in the clinic in Valens. We just happen to have a picture of Valens. I like to show the people where we work. Yes, it's nestled up in the mountains. It's really quite nice. And they have been coming there, or had been coming there annually over many years. The head of our medical department is a friend of theirs, and we were lucky enough to have them come annually. They're not coming anymore because both of them are getting older and they're not traveling as much. But that's how I got involved, and it's just been continuing. Mm-hmm.
So the Bobaths were clearly, well, for a long time now, have been working toward increasing the quality of hemiplegia care. Mm-hmm. Let's focus just a little bit on hemiplegia itself. Will you talk to us about things like incidence?
Oh, yes. I think we have to talk about that first so we realize, I mean, most of us are watching this teleconference today because we have so many stroke patients, mm-hmm. and we want to know what we can do to improve the quality of the treatment. But what about incidence rate? Now let's take a look. I think you have in your manual also a little graph here about the annual incidence rate of stroke related to age. This is incidence per 1,000 per year per age group. And here we see what we would expect actually. The main patient group is probably older, 75 to 85. And that's not unusual, but I'd like to make a comment that there are quite a few patients who have had cerebrovascular accidents, or CVAs, who are very, very young. And about a mean age in our clinic of CVAs at one time was 54 years old, and that's not very old. And we wonder actually about, for example, risk factors. What are risk factors involved with stroke? Good. We have some of the more common risk factors. I'm not saying that this is all or the only, but I mean, yes, hypertonia or heart disease or smoking. And if we have one of these problems, or more often more than one of these problems, yes, the risk is greater.
Multiplies geometrically.
Yes,
almost,
it really does multiply, yeah. And we could look at maybe the age or life expectancy of these people once they have had a stroke. Now, we have a chart here that shows approximately how it looks in the United States. Now, this, we had in 1981 in the United States 414,000 CVAs, or strokes. Of these 414,000, 183,000 died, and 231,000 of these people survived. Now, that is just 1981. That's in 1 year. And we're wondering, where are they?
Exactly. Almost 250,000 people who have had, out of the almost 500,000 people who have had strokes, survive, and yet we don't really see people in the community who are recovering stroke patients. Any theories about that?
Well, I guess so. This is an amazing thing. I mean, when we take a look at a stroke patient, I mean, what do they look like? We have a slide of one that we should just look at. I mean, we're rehabilitating them usually with, this man does not have a brace, but we could have a brace. He does have a quad cane, that he does have an arm sling. He is not really symmetrical. He looks like something's wrong with him. And I think any of us, especially, I mean, whether we're old or not, I mean, what does old mean? We would not like to walk around in public like that. And this point I would really, really like to make is that, good, let's say the mean age is 65. What are 65-year-olds doing these days? They're not sitting at home and watching television, and they're not happy with a passive life. They're going, I don't know, to Florida or Hawaii on vacation, and they're leading active lives. Maybe they're going square dancing, I don't know. But we're not happy with sitting at home. And if someone looks like this, maybe has a facial paralysis, maybe they're having problems, they're drooling, maybe they're not able to cut their own meat, maybe they can't eat by themselves, they're certainly not going to go into a restaurant. And they're certainly not going to be walking around downtown Pittsburgh or downtown wherever, because it is really embarrassing. And this is something that I think we are becoming aware of. We're realizing that the quality of their lives is not very good. They're living a long time because they're actually healthy again, but the quality is not there. And therefore, we're looking back and thinking, well, you know, what's the quality of my treatment? Where am I missing here? What am I not doing right? There must be something more than what I'm giving the patients, and that's why we're looking to the Bobath method.
To absolutely maximize the potential, because whether you're 95 or 35, if you just want to be able to do everything that your potential will let you do, and that's the reason, I guess, basically for the Bobath approach.
Yeah, that's right.
Yeah. How widely used is the Bobath approach in the United States? Is it used very widely, or is it found mostly in therapy departments or in nursing? Or?
I think it's a technique that's been used quite a while over in Europe, and it's a technique that's had a lot of success. It's getting started in the United States. People have used it for a number of years, but only in selected areas, probably more in rehabilitation centers and hospitals. The demand is there. People are interested in knowing more about the techniques because people are frustrated with the work that the results that they've been seeing. They want to bring the patient a step further. It just doesn't happen. And on the other hand, They need more information on it. The demand is there, and that's why we're hoping to get some of this information across today. We don't expect people really to be Bobath trained therapists at the end of this, but hopefully they can take some of this information and try using it in their clinics.
Sure, and just to realize that the Bobaths have shown for sure that there is more that can be done.
That's right.
Okay, fine. Well, keeping these basic premises in mind, we will explore next some of the principles on which this Bobath approach is founded. The key concept behind the Bobath approach is best understood if you have a clear understanding of movement. The Bobath goal is to try to normalize as much as possible the patient's movement patterns given the patient's existing potential. But of course, in order to recognize abnormalities in movement and balance, we have to have a good understanding of what normal movement is. Louise has moved over to our demonstration area where, assisted by Harmarville physical therapist Clara Lozano, she will demonstrate some of the principles of normal movement for us. Louise?
Good. Thank you, Susan. As Susan said before, I think before we get into treating the abnormal, we have to be really aware of what is normal. How do we move normally? Why aren't we always falling all over when we want to walk someplace? And that is a major point. In a really large, let's say 3-week course, we spend at least a day to a day and a half practicing these things and observing normal. So what I'm going to show you now is just a short observation of what normal is. Good. Now, the Bobaths, Dr. Bobath said that the normal postural reflex mechanism consists of a great number and variety of automatic movements which gradually develop along with the maturation of the infantile brain. Now, good. What are these automatic movements? Let's show you some of these. First, let's take the writing reactions. These are automatic reactions which serve to maintain and restore the normal position of the head in space, that is, the face vertical, mouth horizontal, and its normal relationship with the trunk, together with a normal alignment of trunk and limbs. Now, I can demonstrate a few of these things for you. Thank you, Clara, for coming and letting me show you. First of all, let's see what happens here when I bring Clara just a tad over to me. Now, not too far that she falls over. Please note that her eyes are remaining parallel to the floor, although she has a reaction here that she won't fall over. I hope. Good. There you are. And go back. She always maintains her head in space and her limbs follow. This is really very important. Your head tells you where your body, arms, and legs are supposed to be. Now let's look at this when she slowly lies down. Now watch her head. She'll come slowly down. There she is, coming down. And when she's down, then the head goes down. Now when she comes to sit up again, please observe the head comes first, and then her body comes. Important. The way the eyes are is a major, major aspect in normal movement. What about, second thing, equilibrium reactions? These are automatic reactions which serve to maintain and restore balance during all our activities, especially when we are in danger of falling. All equilibrium reactions, tone changes, and movement have to be well coordinated, quick, adequate in range, and well timed. Now this is important. Clara, could I have you here? Good. Now, what exactly do we mean by equilibrium reactions? We mean something that looks like this. Good job. Thank you for not falling down. We're showing normal today, yes. Good. Now let's take a look at this again. I'm going to shove her quickly. She will not fall. We'll do a lot of gymnastics to keep ourselves on our feet. Now this is really important. It's quick, it's well timed, and she comes back into the middle. Now if I just bring her off a little bit, she's not going to take a big step. She's coming out with her arms, but when it gets too far, she'll go over. She'll cross over. Good. Now if I bring her back a little bit, what happens here? Her toes come up, her head comes forward, arms forward, and then when she can't hold it anymore, then she goes back. But she saves herself. Same thing with going forward. I'll push her forward. She's going to try to stop it, and then she has to go. We'll try to save ourselves without moving, but when we have to, we will, and it's fast. Good. These are equilibrium reactions. Now, the last one I want to talk about are automatic adaptation of muscles to changes in posture. This allows for smooth and well-controlled mobility against the forces of gravity. Now, this is what we call in, so to speak, Bobath language as placing. We call it placing. And the easiest thing for all of us to think about is we're going to the hairdresser, we're sitting there, and she's cutting our hair. And she's moving, moving. She's not telling us, now move your head to the left a little bit. No, stop, put your chin down. And so she moves our head, and we follow. She doesn't have to tell us a thing. Our muscles are taking over the new position without any further ado, so to speak. If I lift her arm up, she'll stay there. Put it out here, she'll take over. She won't let it fall. I can do all sorts of things here. She'll follow me. Good. All right. Fine. The muscles adapt automatically. We don't think about this. Good. Thank you, Clara. Now, Dr. Bobath says there are 3 prerequisites for voluntary functional activities. The one is this normal postural tone of moderate intensity. It's high enough to resist gravity, but should be low enough to give weight to movement. If my muscles are so tight, I can't move. I'm too stiff. But on the other hand, if I'm too low tone, I also can't move because I can't hold myself up against gravity, right? Good. Another thing, the normal reciprocal innervations of muscles. That means I have to have fixation proximally in order to move distally. I can have a wonderful hand, be able to do all sorts of things, but if I don't have shoulder control, I can't do much with my hand. Or the automatic adaptation of muscles to change in posture, as we've seen, and the graded control of agonists and antagonists integrated with that of the synergists for timing and direction of movement. All these things we need. The last thing is the automatic movement patterns of the righting and equilibrium reactions. These things are the background against which voluntary activity takes place. That's normal. Now let's take some more look at normal. Something really easy that all of us do every day, probably more than once, and I'm sure it's more than once, is sitting to standing. Now, how does one normally stand up from a chair? Say, yeah, you put your feet down and you get up. Good. But we have to observe, how do we do that? How far do we have to go forward until we're ready to stand up? Now let's look at this. Please observe with me. Clara, could you very slowly stand up? There she is, and up. Now where does her center of gravity go here? Come and sit down again. Head up, and sit down. She comes until her upper trunk is way over her feet. That's how far we have to go. Now stand up. Good. It's far, isn't it? What happens when I give poor Clara here a really low chair? I want you to do it again slowly, Clara, all the way up. She has to bring her feet back. She has to get her feet under the center of gravity. It's not enough. She has to add extra leverage onto the front. Otherwise, she cannot stand up. Could you sit down again? And the point I'm trying to make is, for all of us who are working with hemiplegic patients, or any kind of patient, how do we ask our patients to stand up? We'll think about that later. Could you stand up again? That's wonderful. And now, I'd like all of you to stand up for me. Now, wait. Also, those of you in St. Paul can stand up. I would like you to stand up to the count of 10. That means when I get to 5, you're halfway up. And when you're to 10, you're all the way up. But now don't cheat. Are you ready? 1, 2, 3, 4, 5. Are you halfway? I'm staying at 5. 6, 7, 8, 9, 10. And now just slowly sit down again and see how far over your weight is. Sit down slowly. All the way down, all the way down, all the way down. Good. I must say, most of you really look normal. That's wonderful. Good. Good. The point I want to make is, remember now, normal is coming forward. That is normal. Good? Now, what other kind of things do I mean? I would like to show you in just a moment a tape we made in Harmarville, and it's a tape of gait and of stair climbing. Now, I don't want to make a big neurophysiological gait demonstration, but let's just take a look at the things I look at. Now, look at the nice rhythm Clara has, really nice rhythm. The tempo's fine. She's fluid. She has a pendular action in her arms. She has rotation through her trunk. Notice how the knee is really coming forward. Her pelvis stays level with the floor, and please note that. There's not hip hiking going on. She has a nice toe off. Now, our patient is not very fluid. He has a stiff gait. He's getting along all right, but it's not that easy for him. It looks difficult. He stands on a very hyperextended knee. He has spasticity in his foot that's giving him problems. He's swinging his leg through with circumduction, also with pelvic elevation and retraction. It's nice to have a slow motion view of this too. Look at the pendular swing. She has rotation through her trunk. Pelvis stays level with the floor. She makes a nice pivot turn without any problems. Look at her now at the toe off. The pelvis stays down, the knee comes forward, foot forward, and heel strike. There's not hyperextension in her knee. She's moving very, very fluidly. And that's really a nice thing to look at. Now, our patient, from posterior view, you see he's bringing his leg through with hip hiking and circumduction. It's just swinging and stands on a very hyperextended leg. Swing through, hyperextension. Hip up, circumduction, and landing more or less on his plantar surface. And each time he does that, it forces him into an extensor synergy again. You see the associated reaction in his arm. Now, what about stair climbing? Now, this is something not most of us, quite a few of us have stairs at home. We have to remember that's a normal activity. Once again, here, her weight is moving forward. She's not hanging back. The pelvis, again, stays more or less parallel to the floor, and she's coming up with knee flexion, hip flexion. Look at how nice that looks. She's not bringing her leg through with hip hiking and then coming down. It's reciprocal. It's normal for us to walk stairs reciprocally. Looking at it in slow motion, she comes down the ball of her foot, stands on a not hyperextended knee, has mobility there, turns around. She can walk up and down, of course, without railings. Here she's coming forward again. And alternating stair climbing. The knee comes forward and up, pelvis stays down. The weight is moving forward. Very nice. Now, what does our hemiplegic patient do? First of all, he can't walk the stairs without holding on. And he's doing a swing too, and just using the involved leg as a stance leg. He's lifting that stiff leg up with pelvic retraction, which forces his trunk forward. Let's watch again. He comes down on a stiff leg on the heel of his foot, and the weight is behind his heels, and that is not normal. His pelvis should be forward. Let's watch him do this going up. He's pulling himself up, swinging a stiff leg up and to the good leg. Here we're going to see it again. Just using the involved leg as stance with hyperextension. He's getting forward flexion in his trunk and pelvis. You see how his pelvis is pulling up his leg. Now, I think we can see, if we think about comparing these two, that is not really normal. And it would be quite a problem if he were going to try to go to a restaurant or go any place outside where there were no hand railings. I mean, he couldn't do it. And that's another answer to why our patients are not being seen out on the streets or in the restaurants. They maybe just physically can't get up there. And this is really, really very important. We have to try to make our patients really independent as a whole person and not as a half. I agree they have had an insult to their brain and they have had one-sided problems, but that does not mean that I can't try to rehabilitate them as a whole. And that's why we're here. And we're going to try to do it in a way that they learn really normal, functional, daily activities, just as we've shown here. Sitting to standing, going up and down the stairs. It might be getting into the bathtub. Yes, PTs, that is for us too, getting into bathtubs. We have to think about, what is he going to have to do at home? And then we think, now, how would I do that? And I try to superimpose that on my patient. That's how I actually know how to treat him. But of course, it's a lot more complicated than that. I know you've been trying, and we'll try to help you along as these several hours go. Good, Susan. Thank you.
Thanks, Louise, and thanks to Clara, too. Jan, it sounds from everything that Louise has said and from what we've heard as though good observation skills are more vital to the Bobath approach than to most others. Is that indeed the case?
I think in general that the observation skills are the most critical, because unless you can observe not only what normal movement is, but also the abnormal movement, you're not going to know exactly what your emphasis is going to be in treatment. You have to be able to critically observe every motion and every movement to know exactly what you should be working on.
How do you take into account, Louise is back with us now, so I'll ask this to you, Louise, the fact that what's normal can vary so much from one person to another? Could it not be that what is normal for one person would it indeed be abnormal for another?
Well, I think going so far as to saying that it would be abnormal for another, maybe not. But there are certain things to take into consideration. For example, we worked on sitting to standing. How far does one have to come forward? Well, someone like Clara, who's relatively short, or in comparison to someone who's very, very tall with very long legs, I mean, that is a change. Everyone has to come forward, but how far? That might change. But I think there's not a real wide variance between really normal and abnormal with everyone.
So it just depends on the particular patient, and
Right.
that's part of learning to observe, is
That's
taking
exactly
into
right.
account things like height and weight and physical condition. So, yeah. Characteristically, a lot of the healthcare personnel who work with hemiplegic patients in various care settings, especially families who are working with hemiplegic patients at home, are not professionally trained. Can they still use the Bobath approach? Can they still learn about movement? And
I think as long as you understand the principles and you know the basics, then I think anyone can take these principles and be able to use them. When we get into more specific facilitation techniques and specifics in movement and treating the patient in the very specific facilitation techniques, I think then you have to take a course and you have to have good supervision from an instructor to know exactly what to do. But the basics, like we'll be talking about today, I think most people could take that information and be able to use that in their setting.
and you would agree?
Oh, I
Louise,
agree.
Susan? Yeah.
Totally.
Okay, fine. Well, of course, the problems of hemiplegia are not confined to muscle weakness alone. There are other associated problems that need to be considered. Next up, Louise will discuss some of these other problems with a detailed look at one that is a particular concern, spasticity. Before we go back to Louise, I would like to remind you that coming up shortly is a question and answer session. So if you have any questions, you might want to refer them to your site coordinator now. The site coordinator can call us collect at area 412-621-7161. The problem of spasticity, or increased tone, is a major problem needing to be addressed in the treatment of hemiplegia. But just what causes spasticity, and how are hemiplegics affected by it? Louise has some of those answers and more for us. Louise?
Good, thank you. I've been working actually almost exclusively with adult hemiplegics or patients with brain damage since 1975. And the more I work with this type of patient, the more I realize I don't know enough, for one thing, and realize that their problems are so great, and it's not just the motor problem they have, that it is what we see, the way we see our patients walking. That's not really always the main problem. I mean, they have so many problems. I'd just like to talk about that for a moment because I think it's important to understand the whole picture. Now, several of these things, for example, let's think of, do they understand what we're expecting of them, for one thing? Now, it could be that they have an aphasia, that they do not understand what we're saying. They can't express themselves either. And this is a very, very frustrating thing, not being able to communicate. I think we have to realize that sometimes when we're getting a little edgy with our aphasic patient, we should remember they have it much worse. This is really a big problem. They're very frustrated. And something for us also to keep in mind is that these people are often very good with the nonverbal communication. If you'll observe your patient, see how he's watching you. And just, he's picking up on nonverbal cues, and if we sort of make a face like this or like that, they're right with us. They know, oh, I did something wrong. Now, what did I do wrong? Or, oh, that was good. Okay. You don't even have to say anything. They watch your face. But it still is so that they're very frustrated with their lack of communication. That is one problem that happens to be quite a large problem. Other problems are, for example, what if they just have a hemianopsia? They do not see the involved side, purely sight. And they're yelling, I didn't get any meat for dinner, and where's my salad? And the nurse is saying, yes, but it's right in front of you. You know, they haven't learned how to compensate yet. They do not see it. It's another problem. What about something like neglect or perceptual problems? They can see it, they're just not, they don't perceive it. Like they might be running into door rims, or they can't wheel their wheelchair because they just don't know where they're supposed to be wheeling it. That's another large problem. What about something like sensation? Can you imagine trying to walk someplace when you do not feel your leg at all? How do you know when your foot's on the ground? How do you know when your weight is on that leg, if it's on that leg? How do you know if you've got your hand caught in the wheelchair spokes? You know something's wrong, but you don't know exactly what. You do not feel it. That is a major problem. I mean, we talked about normal balance reactions. They may have spasticity, they may have hypotonicity, and therefore, due to these things, they are not able to move. They are locked in a posture that they cannot get out of, and they can't react. They may have planning problems. This is something that's been a real eye-opener to me. I think the occupational therapists probably are involved quite a lot with this. I don't think the physical therapists, maybe the nurses are more aware of it than we are, but I've been doing a lot of dressing. As a physical therapist, I do dressing in the morning, and have had my patient take his deodorant and stick it in his mouth, take their toothbrush and comb their hair, put their underwear over their head. I mean, all sorts of weird things that they know they're supposed to be doing something, but they don't know what. They don't know what to do with this material. They can't find the hole for their shirt. It's really, really awful. And these things we have to work on. And we can do something about it. And we'll be talking about these different methods later. But I just want everyone to really be aware of the fact that hemiplegics have more problems than just the motor problems. Okay? Good. But of course, we like to talk about the motor problems. And let's talk about spasticity first. Now, Dr. Bobath has a definition of spasticity, and he says that spasticity is caused by the release of an abnormal postural reflex mechanism which results in an exaggerated static function at the expense of dynamic postural control. That is how Dr. Bobath explains spasticity. Now, I was talking to an occupational therapist, Linda DeJoseph, who is an associate professor teaching neurophysiology at the State University of New York at Buffalo. And I said, Linda, what is the latest theory on spasticity? And she said, well, I'll give you 9 possibilities. And I said, 9? She said, yes. So I have decided to give you these 9 things she gave me. And I'll be totally open with you. I don't understand them all myself. So here they are. 1, the removal of presynaptic inhibition of the 1A circuit. 2, hyperactivity of gamma motor neurons. 3, central nervous system plasticity. 4, alpha motor neuron mutability. 5, postsynaptic supersensitivity. Good. 6, deficit in reciprocal innervation. 7, depression of autogenous inhibition. 8, depression of recurrent inhibition. And 9, abnormal spread of impulses. Yes, well, here are your 9 possibilities. I mean, the experts are not sure what exactly the pathways are for spasticity. And I really can't tell you either. But what I can tell you, and what we've all observed, are what are the typical postures and what are the typical synergies of spasticity. We've all seen it. Now, we have, of course, more than one synergy. But I'm going to work through today just one of the more typical that we see. And I have a little man here, done by the graphics department at Harmarville. That looks very nice. And he is going to be our spastic person. Now, what is spasticity? What does it look like? First of all, it is not just an arm and a leg. We have to get away from that concept, because if we try to treat arms and legs without everything that's above and in between, we're not going to do the best job that we can. So let's start up at the head. Good. He is a right hemi here. So he has lateral flexion toward the involved side and rotation away from the involved side. Now that makes it a problem already, because his spasticity is pulling his head away from his involved side, which means that that causes him to pay less attention in the first place, purely the spasticity. Good. Now, the shoulder girdle, upper extremity. The scapula is in depression and retraction, pulled down and back. The shoulder is in adduction, a deduction, internal rotation, elbow inflection. Forearm is usually in pronation, the wrist in flexion with ulnar deviation, and the fingers in flexion. We could have a little bit more flexion here, but it can be like that too. So that's this posture up until now. And make sure you pay attention. You'll see why later. Good. Trunk. The trunk is really very, very, very important. I just want to say that often when the arm even looks hypotone, you'll find the spasticity developing right around here. It's already there, but we haven't seen the extremities yet. But the trunk is usually in lateral flexion. Now, moving down to the pelvis, we're going to have posterior elevation of the pelvis, retraction. The hip will be an internal rotation, adduction, and extension. The knee will probably be an extension, ankle in plantar flexion, supination, inversion. The toes will be in flexion. Now, you can see that, you can imagine that when the shoulder is pulled down and back and the hip is pulled up and back, that you're going to get the same effect as what I just did, rotation toward the involved side. Now, if I lose my balance and I have rotation towards the involved side, where am I probably going to fall? Towards the involved side. And the most common problems after a fall in a hemiplegic patient are hip fractures and radial fractures, and maybe shoulder trauma, because they're going down onto the involved side due to the spastic rotation. Yeah? Now, I think this is really very important. We have to understand our patients and what they're feeling. And the best way to try to understand what they're feeling is to try to feel it yourself. So would all of you please once again stand up. And all of us normals are going to become spastic. Good. Now, I'm not going to start with the head because I want you to be able to look at me for a moment. We're all going to be right hemiplegics. Ready? Now, first of all, let's make a fist and flexion. Down. Keep it, but make it tight. No cheating here, really tight. Good. Now bring your elbow over your navel. Really point to the navel. Keep that wrist down. That's right. Good. Now what we're going to do is shorten the trunk, like that. Oh, that looks good. Now, point your toe and bring it over the midline. But make your legs shorter. It should be about 12 inches shorter than normal. Come on now, stand on one leg. That's very good. Point it and twist it as if you're going to come down on your lateral malleolus. Twist it. And now we're going to put our ear on our right shoulder and look up to the left. Oh, dear. Look up to the left. Now make it tight. Pull, 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 pull. And let go. Oh, dear, I have to inhibit myself. Good. Would you please sit down? Now, it's always interesting to see this reaction because of the fact that everybody's, wobbling around and trying to hold their balance. Did you feel that? First of all, it's not easy standing on one leg like this. And it's not easy standing on one leg when the other side is all asymmetrical. The balance is difficult. That's not only difficult for us, but that's difficult for our patients. Another thing is, making your muscles work that hard and be that tight is not comfortable. That hurts. And if you do it properly, you can really make your muscles cramp that much that you cannot let go. And that's what our patients feel all the time. And I think that is important for us to understand. And it's important for us to understand that if someone has this problem, we don't just go up to them and say, oh, would you please relax? Now, come on, relax. They can't relax. They would have relaxed 4 weeks ago. But we can do something about it. And that's what I want to tell you then in a moment. Good. The effects and characteristics of spasticity, just to mention them again, there's probably a loss of motion, a pure loss of motion due to this co-contraction. There is an incapability of voluntary control. These, by the way, spastic muscles are not necessarily strong muscles. They're under contraction all the time, but strength indicates that you can do work with it, but they can't work with them. It's just tight, yeah? It prevents, obviously, normal postural reactions. When I'm stuck in this posture, I cannot react. If I start falling over there, I cannot do as Clara did and take a step and save myself. I can't. And even if I'm falling to this side, this leg does not come out. It can't react. It's stiff. So that's a big problem. No postural reactions. That's why we're always afraid of them falling, right? We have really a very abnormal sensory feedback. With all that tension, they're not getting the right information from their environment, be it from the leg, from the hand, from the arm. It's not the right information. They can't react correctly because the input's coming in strangely. They may have, after a while, real weakness in the antagonistic muscle group. If the flexors are under contraction all the time, eventually the extensors are going to lose their ability to work. But it's not automatically a problem of weakness. That's not the problem. Good. Now, what factors influence spasticity? We can look at a couple of things. Fear. Now, if someone is really frightened, it's just like a baby with a reflex when both arms come out. But once they've reacted, they're back to normal. But if a hemiplegia goes, they're up there again, and then it stays. It doesn't let go. When they're frightened, they will have more spasticity. When they're under stress, for example, the aphasic who's trying to speak to you, can't get it out, he's under stress. And you'll notice right away the associated reactions or this increased spasticity coming. And that's a clue for us. Good, we have to do something and stop this, that the person feels more relaxed, that he's not trying so hard. Or what about emotion? Have you ever gone in like on Monday and said, "Hi, Mr. So-and-so, did you have a nice weekend?" And they're labile, they'll start crying and they'll get spastic and you say, "What did I say?" You know, this is this lability. They're very, very, very emotional. And this emotion will trigger the spasticity also. Good. Effort. That's why we're, in this method, we try to stay away from effort. Don't make it hard. If they're trying to pull on something to get themselves out of bed, for example, their arm is going up and back, and they're more spastic. We have to make things easy. Take things in small steps. Make it easy. Don't make it hard. And another thing is pain. If there's any sort of pain, they'll get a reflex. Pain is an incredibly strong reflex. Don't make anything hurt, if possible. I mean, most of us don't want to. In Switzerland, they say, "Yeah, but it has to hurt for me to get better." And I said, no, it doesn't have to hurt, okay? And temperature, sometimes if there's a big change in temperature, like it's really cold outside, I mean, we start shivering too, and they may also have an increase in spasticity in that situation. Good. But the thing that we want to know is, yes, but what are we going to do about it? Good, I'll tell you. First of all, we have to do what we're calling normalize the muscle tone. Try to make the spasticity release. And we do that by, first of all, proper positioning. Now, when I talk about proper positioning, I mean positioning in bed. Jan will be demonstrating, talking about that later. Positioning sitting in the wheelchair. A lot of our patients are in the wheelchair most of the day, and if they're not sitting correctly, that will increase their muscle tone. That's not what we want. Weight bearing. Weight bearing is so important. If you're lying on your side, you're bearing weight through that side. That will release the spastic muscle tone. If I'm standing on my leg, but fully on my leg, I'm once again inhibiting the spasticity. And it's amazing. If I really stand on my leg, but really full, all of a sudden my arm goes down. Everything is connected. Everything. A PT can't, or an OT, let's say, can't sit in OT, the patient sitting in a chair like this, working like this, and expect the patient to do his best. He has too much increased tone through the whole side. You have to look at the leg, you have to look at the hip, you have to look at the trunk. Automatically, your treatment will be better. Trunk rotation. The trunk is very important. This movement will also inhibit the spasticity. Rotation in rolling and sitting. Be careful when we have finally normalized the tone, the muscle tone, and we feel, oh, that's really, what should we say, relaxed. Then we think, all right, now let's try to do something, for example, with the hand. That's exactly right. We want to put normal function into this more or less normalized muscle tone. But then we have to be careful. If all of a sudden they're trying real hard and I can feel it getting tight again, that means that was too much. Stop. Inhibit that all again and start over, but don't ask for so much. We have to grade the stimulation very carefully. And sometimes, even though we're careful, it will increase the muscle tone. But all that means is start over. Don't try to put more on top of something that's already gone wrong. Once again, inhibit and try the functional activity again. But remember, normalize tone and then put function, normal function, on top of it. Good. Once again, avoid effort. Avoid effort. You don't need to make it so difficult. It will cause associated reactions. Try to facilitate these normal, automatic, postural reactions. Only through practicing these things are we going to be able to allow our patients to learn it. I mean, that's the whole idea, to teach them that again. And try to provide really normal sensory experiences, that they feel what it's like. I've had it really quite often that a patient will be maybe in PT, lying on his involved side, and I feel that the hand, the muscle tone feels really normal, and he'll say, oh, I can really feel that. And for me, it's maybe not that obvious, but for him, it's something incredible. He or she hasn't had that experience for a long time, and only when they feel what normal is can they start regulating that themselves. We have to give them that experience. And please, please train the person as a whole. We're not just a half. We are a whole. And teaching them to compensate, and walk around like that, you can say, yeah, but he's getting around. Sure, he's getting around, but where is he getting around? From his bedroom to the kitchen. And the quality of his life or her life is really, really nothing. And don't forget that these patients aren't so old. And what does old mean anyway? Okay? Good. Thank you. Susan?
Thank you, Louise. Well, summing up what Louise has said, then, we've learned that there are various factors influencing spasticity, and that as therapists, nurses, or family members, we have to be aware of those factors and learn to modify and reduce spasticity through the use of some very specific techniques. In our next content area, 24-hour management of the hemiplegic patient, we will learn a lot more about these techniques. But first, we're going to open our phone lines and take your questions and comments about Bobath history and principles, about normal movement, and about problems in hemiplegia, including spasticity. The phone number to call collect again is area 412-621-7161.